Sir, we are live on IN YouTube channel.
Okay. We'll wait for a couple of minutes and then start.
Okay, sir.
We already have 100. Should we start, sir?
Think.
Yeah, I think that's a very good idea, Rakesh. Let's
Yeah.
start.
Yeah. Yes. So, good evening, everyone, and welcome to this first meeting of. We do it every 2 monthly. The first meeting of this year, and this is a 2 monthly regular meeting which we conduct on behalf of the Neuromuscular Subsection of Indian Academy of Neurology. And this is done by various institutes across the country. This time it is being done by Bombay Hospital and Research Center and Sir JJ Group of Hospitals, Grand Medical College. The theme today we have taken is refractory syndromes, and we have three talks. And the first talk is on refractory CIDP, and this will be done by Dr. Hiral. Dr. Hiral has recently passed out DM from Bombay Hospital, and she was trained by Dr. Khadilkar sir, and she worked as a consultant at Bombay Hospital. And let us welcome Dr. Hiral for her talk.
Thank you, sir.
Yes, sir.
I'll share my screen, sir.
Yes, yes.
So, good evening, everyone. I'm Dr. Hiral Halani, and today's first topic for today's discussion is refractory CIDPs. So, outline for today's talk is basically first the concept of refractory CIDPs, the definitions, their prevalence, when do we call it refractory, and then understanding the pathomechanisms of CIDP, which will define the treatment targets and the management strategies. And some case examples of treatment responsiveness of different CIDP variants and CIDP in presence of concomitant diseases. So these are the outline. So basically, CIDP was introduced initially as clinically as chronic inflammatory polyneuropathies which are responsive to corticosteroid. So responsiveness to steroids was the defining characteristic. And now we are moving beyond this concept. We are calling it refractory. So this is just the introductory part. We know how does a typical CIDP presents with chronic progressive, stepwise or recurrent symmetrical proximal and distal weakness, sensory and motor weakness. Now, before calling it refractory, we should first know the natural history of CIDP, that it does progress over 2 months, and the peak of disability is achieved usually within 5 to 6 months. And thereafter, a recovery phase follows, which usually lasts about 12 months. So this is typical of an average bout of first one episode of CIDP, and then there can be recurrences, which can be variable in severity and duration, usually after months or years of asymptomatic intervals. So recurrence should not be defined as refractory CIDP as long as it is responding to the conventional therapies. And even early recurrences, whenever the early recurrences were studied in case of CIDP, the first possibility which was found out, that was the premature stopping of steroids which leads to early recurrence. So this again does not qualify for a refractory CIDP. So how common is this refractory CIDP? So usually 70 to 80% of the typical CIDPs, they will respond well to the first-line therapies, which are IVIG, corticosteroids, and plasma exchange. The remaining 20 to 30%, they do not adequately respond to these therapies and they require second-line therapies or combination of first-line, second-line therapies. And even after these interventions, about 15%, 5 to 15% will remain refractory to all of these treatment. So how do we evaluate a case of refractory CIDP? So again, reports have shown that there are two most common causes of refractory CIDP. First is incorrect diagnosis and second is inadequate immunotherapy. So first and foremost thing is to carefully look for CIDP mimics. Now, literature reports that nearly as much as 50% of cases were referred as refractory CIDP that turned out to be ultimately to be alternative diagnosis. And this is the list of CIDP mimics which one should be carefully ruling out while before calling it refractory CIDP. And when they compared these patients who ultimately received alternative diagnosis and not the refractory CIDP, there were certain clinical features which were different from typical CIDP. So the distal weakness, loss of vibration, and absent knee jerk, and not the ankle jerk, is specific for CIDP. So loss of ankle jerk is not a specific feature for CIDP, whereas loss of knee jerk is a specific feature of CIDP. And in nerve conduction study, apart from other demyelinating feature, what is more specific of CIDP is distal temporal dispersion. So we should be carefully looking out for these features to to rule out CIDP mimic. Now we'll understand with this one case example. There was a 65-year-old male who was symptomatic of about past 4 to 5 years. Started with asymmetric proximal lower limb weakness, knee and hip weakness, and followed by distal lower limb and distal upper limb weakness. And this was the man. We can see the striking wasting of FDIO and the interesting hand muscle. And the first diagnosis that comes to our mind is motor neuron disease, which was in fact the referral diagnosis. Again, there was more wasting. On careful examination, there was proximal lower limb and distal upper limb weakness. So this combination again gives us a thought of IBM kind of weakness also, with proximal lower limb knee wasting and distal upper limb weakness. But then again, there was mild sensory involvement in form of very distal diminution of proprioception and vibration, and mild sensory ataxic features and hypo to areflexia. We went ahead with electrophysiology, which gave us the final diagnosis, which was motor predominant CIDP, and MR neurography also showed the compatible thickening of the nerve roots and at the plexus level. So he didn't respond to steroids at first and then improved with IVIG to some extent. So this case emphasizes that not just the CIDP diagnosis, but even the identification of correct variant is equally important to guide the therapy. Now we know that there are many CIDP variants, and recent addition of these nodopathy, paranodopathies have made this classification further complex. So if we look at some of the CIDP variants, the pure motor or motor predominant variant, which we, just like our case that we saw. So in literature, early literature, there was a concern that these patients, they are typically resistant with, to steroids, or they even worsen with steroids. And this even led to the recommendation in guidelines that they should be given IVIG as first line of treatment and not the steroids. But then recent data have shown that there is not significant difference in the responses of motor and typical CIDP. The overall response rate is comparable to typical CIDP. If we look at another CIDP variant, with this case example of a 60-year-old male, non-diabetic, who came with chronic progressive distal paresthesias in both legs and sensory ataxia, progressive for 2 years, minimal distal motor weakness in the legs. Nerve conduction was typical of distal demyelination, and CSF protein was raised. So this was classic phenotype of DETS. We did the IFE, and there was M band in the IgM monoclonal protein, and anti-MAG antibody was also positive. So this DETS phenotype, when it is idiopathic, it is usually benign and prognosis is favorable. But when this DETS phenotype is associated with IgM paraprotein, like in our case, they usually do not respond satisfactorily to the conventional CIDP therapy, and there the recommendation is to use rituximab early. Another option for these patients is to use tyrosine kinase inhibitor, ibrutinib, because 50% of them have genetic mutation and they produce Waldenstrom microglobinemia, and there this Bruton tyrosine kinase inhibitor, they are helpful because of the anti-neoplastic effects. Another variant, MedSim. Now here the pathology is little different from typical CIDP. Here the pathology is multifocal, and the mid-nerve segment and proximal segments are more involved rather than as opposed to typical CIDP where proximal and distal nerve terminals are involved. Now proximally and distally, blood nerve barriers are loose and less intact. So the humoral factors, antibodies, are more involved in pathology rather than cellular factors. So these differences in the pathology will account for the differences in treatment responsiveness. In this MedSim, when compared to typical CIDP, they have shown poor treatment responses to first-line agent, corticosteroid and IVIG, and the long-term outcomes in remission are inferior, and hence more use of second-line therapy with rituximab and cyclophosphamide. Pure sensory CIDP responds as good as like typical CIDP to the conventional therapies. And there was this study in the Frontiers Neurology in which they compared the characteristic of patients of refractory and non-refractory CIDP. And particularly the important thing to look at is that amongst the CIDP variants, they didn't find much of difference between typical CIDP and atypical CIDPs in each group. About 50% each were typical and 50% were atypical. So this was not a differentiating factor between refractory and non-refractory. The treatment responsiveness was much better in non-refractory group. We can see 90 to 100% responses to first-line agents, whereas here the responsiveness was about 40 to 50% in case of refractory CIDPs. Now, managing refractory CIDPs, first we'll need to understand the pathomechanisms. So basically there are two distinct mechanisms. Classical concept is the macrophage-induced demyelination. Here what happens is that macrophages produce stripping of normal myelin, as we can see in the first diagram. And this demyelination is site-specific, which can be triggered by antibodies, complements, etc. But now there is an emerging concept of nodopathy, paranodopathy, where what happens is that the mechanisms are different. And here we can see the myelin is not completely stripped off, but there occurs a gap between the myelin and the exolemma. Whereas in the diagram below, B, we can see the normal myelin is tightly opposed to the axon, whereas in upper diagram, the myelin is separated from the exolemma, which is produced by the antibodies targeted to nodal or paranodal region. And this phenomenon is called paranodal dissection. So the neurophysin isoforms, which we are aware of, are three mainly: NF140 and 186 at the nodal region and NF155 at paranodal region. And now what that sets them apart from typical CIDP is that these are IgG4 antibodies, which differ in the pathology. They will not provoke macrophage-induced phagocytosis. They will not provoke classical complement deposition and inflammatory processes. They'll just block the antibodies and NF155 and 86 and prevent the ion channel homeostasis at the nodal and paranodal region. And hence the treatment strategies here will differ. This again the summary of both the mechanism, macrophage-induced and non-macrophage-induced with the IgG4 antibodies. These are some nice reviews of nodoparanodopathies. So these are characterized by pathophysiological continuum from transient now conduction failure to axonal degeneration, and conduction block occurs because of the paranodal myelin detachment, which leads to ion channel impairment and disturbance in homeostasis. Again, we'll take one case example of this nodopathy. 42-year-old male came with subacute sensory ataxia and postural tremors, as we can see here, distal motor weakness. Here we can see the sensory ataxia and foot drop. His Romberg's was positive. This case was NF186 positive, CSF protein raised, and he showed good response to rituximab and is recovering currently. This article summarizes the clinical features of NF186 compared to 155. And what is important is that two main differentiating features between these two. One is tremor and CNS demyelination. These two are much more frequent in NF155 compared to 186. And the treatment responsiveness, of course, differs. IVIG and steroids works far better in NF186, about 70-80% response, whereas in NF155, 20 to 40% response. And this brings us to one more entity, just to mention in category of refractory CIDP, this combined central and peripheral demyelination, CCPD, which is usually commonly reported with NF155 antibody, where there occurs sequential or simultaneous involvement of central and peripheral nervous system. Here what happens is these IgG4 antibodies will produce subclinical demyelination of the optic nerve and trigeminal nerve and will produce MS-like lesion in the periventricular region, and will in peripheral nervous system will produce proximal nerve root hypertrophy like CIDP. So in case of refractory CIDPs, when do we suspect nodopathy, paranodopathy? So clinically, when there is acute to subacute onset, predominantly distal motor neuropathy, rapidly progressive, severe disability at nadir, severe sensory ataxia, tremor, neuropathic pain, cranial neuropathies, autonomic dysfunction, early axon loss. They can have associated disorders like nephrotic syndrome and paraproteinemias. Important thing about neuropathy is that they are typically less responsive to IVIG and responsive to plasma exchange and rituximab. So early use of rituximab is favored. Another will take one more example of a refractory CIDP. Here there were two cases that we saw recently, which who came with acute onset fulminant GBS-like presentation, and on day 2 they went on ventilatory support. One of them was NF155 positive, other one was 186 positive. Now 155 positive patient, he showed poor response to steroid and IVIG both, and because of hemodynamic instability could not do plex. Whereas the other patient, he was young, and we went ahead with plex, and he at least could be weaned off ventilator after plex. And he's also been given rituximab, and we now are waiting with the response. So what happens in this GBS-like onset presentation, that initially the antibody class is IgG2 and IgG3, which are responsive to the typical conventional therapies, but then they switch to a different class of antibodies, which is IgG4, and which will produce progressive course from the acute GBS-like beginning. But nevertheless, it is important to differentiate acute onset CIDP from GBS because the treatment applications differ. Acute onset CIDPs should be considered when a patient with GBS deteriorates after 9 weeks from onset. Usually the treatment-related fluctuation occurs within 8 weeks, and this will deteriorate after 9 weeks from onset. Or whenever the TRF, treatment-related fluctuation, occurs 3 times or more, again acute onset CIDP should be suspected. Now there have been several definitions given to refractory CIDP. The one which is based on purely neurologists' personal judgment and perspective is like poor treatment outcome based on one's own judgment and experiences. Then this should be not encouraged, and we should apply objective scoring system before calling it refractory. And these are the scoring systems which have been introduced for CIDPs: INCAT, IRORS, MRC sum score, and grip strength. And we have been currently using these scores for our CIDP patients. The another definition which we commonly use in our practice is that patients with CIDP who do not respond to one or two of the 3 first-line therapies, which is IVIG, steroid, and plex, then we call it refractory. So the first step in case of refractory CIDP is either to combine or switch amongst the 3 first-line therapies, and then comes the use of second-line therapies. Now, once the diagnosis is established, the first step is to optimize the therapy, which involves maximizing the frequency of maintenance IVIG or either adding plasmapheresis or corticosteroid. Now, some studies have shown that the most frequent intervention required for inadequate response was increasing the frequency of maintenance IVIG to bi-weekly dosing. Now, usually we give it at interval of 3 to 8 weeks, according to the half-life of IVIG. But in case of inadequate response, we can increase the frequency to bi-weekly dosing and before calling it a therapeutic failure. In other patients, we have to add either plasmapheresis or corticosteroid in combination with IVIG. Now, this novel method of giving IVIG in plasma exchange alternatively, the zipper method, it has been described in GBS, but in CIDP, no data is so far. No data is available. Second line therapies. This is the list of second line therapy, and we'll see them one after the other. So first one is everyone's favorite is rituximab, and there have been the evidence in CIDP is building up. For rituximab case series and several case reports have suggested successful use of rituximab in refractory CIDPs. Few of them I've enumerated, in which there are number of cases are few, but the response rate they have achieved is quite satisfactory, about 60 to 70% response in case of refractory CIDPs with rituximab. The next one is cyclophosphamide. Now, there was a systematic review of 13 studies put together, which reported efficacy of cyclophosphamide to be close to 70% in case of refractory CIDP. And then they have suggested that cyclophosphamide might be recommended therapeutic option for patients with refractory CIDP, especially those who are unable to accept rituximab treatment. Earlier, the better. And better choice for patients with concomitance of refractory CIDP with cancer, but non-lymphoma cancer. For lymphoma, rituximab, of course, is the better choice. But for non-lymphoma, cyclophosphamide should be preferred over rituximab. The next one is bortezomib in CIDP. Now, not much of literature is available on bortezomib, but there was this case series of 10 patients with severe refractory CIDP who have failed first line and second line therapy, including cyclophosphamide and rituximab. And when they were given bortezomib, 1 or 2 cycles with antibiotic prophylaxis and everything, and they noticed stabilization in half of the patient and improvement in the half of the patient with bortezomib. So these 3 drugs are the main agents in second line therapy: rituximab, cyclophosphamide, and bortezomib, and they were studied in this retrospective cohort analysis, in which about 26% of 181 patients were refractory to these first-line agents, and they were given these 3 drugs in different combinations. And what they noticed that whenever these 3 drugs were used within 24 months after the diagnosis, the response rate was much better compared to whenever they used more than 2 years after the diagnosis. So they should be used within first 2 years. The next one is hematopoietic stem cell transplantation. Now, again, this is very nascent and evolving aspect in CIDP. This paper has described data on 60 patients with follow-up of 5 years, and they have reported good survival, and they have achieved their endpoint, which was a percentage of patients remaining immune therapy free after transplantation, which was about 70 to 80%, which is quite a good number. Another strategy in refractory CIDP is repurposing the MS therapies for CIDPs, the rationale being shared immunopathological features with MS. But most of them have been negative. Most of the trials with interferons, glutaramine acetate, DMF, fingolimod are negative, no benefit in CIDPs. Except for anti-CD20 therapy, the evidence is, of course, strong. Proton tyrosine kinase inhibitors do have some evidence, especially in presence of paraproteinemias with CIDPs. And IL-6 receptor antagonist, which have been recently approved for NMOSD, but not relevant for CIDP again. Complement inhibitors, they have been studied for GBS, and similarly, they can be studied further. They are relevant in CIDP pathology. Now, whenever CIDP is present with other comorbidities, so we'll take this example of 45-year-old male who came with rapidly progressive distal more than proximal weakness, severe sensory ataxia, and axon loss, axon plus demyelinating neuropathy in nerve conduction, but there was severe wasting and severe axon loss. So this was a severe CIDP with all the hallmark features of POEMs, as you can see, the systemic features, skin changes, plasmacytoma, endocrinopathies, and he was having this M band on protein electrophoresis. So identification of these syndromes are important because again the treatment strategies will change. These are the strategies for POEMs, and this particular patient received the carfilzomib, which is the congener of bortezomib, and he is currently doing well with the immunotherapy. Sometimes it can present with SLE also. When SLE is active, corticosteroids immunosuppressive like cyclophosphamide should be used. When SLE is inactive, then the standard CIDP therapy can be followed. Now I would like to end with one last case example, which is the interesting one. A young male, 22-year-old male with normal developmental history. He came with repeated GBS-like episodes, and till now he has had 4 or 5 such episodes, and every time he would respond to IVIG, but some distal weakness will remain residual every time. So currently what he has is bilateral foot drop, distal upper limb weakness and distal lower limb weakness, and sensory ataxia. So on EMG and neurography was supportive of CIDP, multifocal demyelination. In neurography, there was contrast enhancement and thickening of the lumbosacral roots. But because he was young and he was not completely responding to the standard immunotherapy, we thought of genetic causes as well. And we did his clinical exome sequencing, from which we didn't get any answer. We did the neurofacin panel was in fashion. So we did this panel, and surprisingly, we got this antibody positive, NF140, 186. And so now we are planning to escalate the immunotherapy with rituximab. But before rituximab, we even did his whole genome sequencing, which has not yielded any pathogenic variant. So this case was to highlight the overlap between the genetic and acquired demyelinating neuropathies, particularly in young adults and children. So should consider genetic testing before escalating therapeutic options in these people, because genetic confirmation for neuropathy presenting like CIDP-like feature is essential for prognostic and treatment application. These acquired CIDP-like features are reported in certain genes like PMP22, GAJB1, MPZ. So the genetic causes should be kept in mind. And this is how we differentiate acquired and hereditary CIDPs. And always there is a degree of overlap between these two. So to summarize, correct identification of CIDP in its variant is important before calling it refractory therapy and escalating therapy. Differentiating between acute onset CIDP from GBS is again very important because it has treatment and prognostic implication. Early use of rituximab and cyclophosphamide in case of poor response to first-line therapies. Identifying concomitant diseases like endocrinopathies, paraproteinemias will change the line of treatment. And in young children with refractory CIDPs, genetic causes should be sought. And under the category of refractory CIDPs, nodopathy, paranodopathy should be actively looked for whenever there is atypical presentation of GBS or CIDP. They are less responsive to first-line therapies like IVIG. So early use of rituximab and Plex will produce long-lasting remission. Thank you.
Excellent, Dr. Hiran. Can you take, there are 2 questions. What is the exact definition of refractory CIDP? Yes.
So, sir, I could find 3 definitions from the literature. One is, as I said, just based on the neurologist's own perspective, so that we should not consider, we should imply scoring and then consider how much INCAT and IROD scoring are improving. So that definition is should not be used practically. The definition which should be used is whenever the patients don't respond to first-line therapies, 1 or 2 first-line therapies, which will include IVIG, steroid, and Plex, then we call it refractory. First-line therapies only. But then some of the references have even included second-line therapies and then call it refractory. But the first-line therapies is used more often in literature, including these 3, IVIG, steroid, and Plex.
Okay. And then you can take this also. Can nodopathy present like acute brachial neuritis?
Yeah, so that will be like a focal CIDP presentation. So conduction block in the brachial plexus, that is possible.
I think you have
Rakesh,
gone.
if you
Yes,
can I tell about a patient experience here?
yes, yes.
Yeah. No, actually, there was this middle-aged male with a flail right arm, and we thought this could be like ALS. It was mainly motor. There was nothing upper motor neuron, and his brachial plexus was thickened on the MR neurography. We recently have got his antibodies done, which shows, I think, 155, but I'm not sure. One of the three antibodies is positive. So as we do antibodies in more and more phenotypes, we'll probably see this expansion of various mononeuropathies multiplex, plexopathies, and various forms which have thickening and which have antibodies. So I think it's a thing in evolution. And on every patient, wherever as a clinician you suspect, it is good to send the antibodies. So it's an evolving spectrum. Yeah.
Absolutely, sir. Absolutely. So I think there are many questions, but probably we will not be able to take all the questions.
I just make one comment, sir.
Yes, yes, please.
Yeah, so one point which when we talk about refractory CIDP is just like what we use in refractory epilepsy also. The first question is in epilepsy is also is it epilepsy or not before going to the refractory, right? In CIDP, in refractory CIDP also the same question should come before going to refractory. Is it CIDP or not? That's the first question. Second thing is EFNS guidelines 2021 has totally taken out the autoimmune.
Vishnu, you're gone on. You're gone on mute.
Yeah, so it is like in a epilepsy definitions and classifications. It will go out and come back in after a few years. But at least now it has gone out of CIDP, autoimmune neuropathies. It might come back later on. At present, all defined autoimmune neuropathies are out of the CIDP and CIDP variants definitions outside. So that's one. So, but in case of refractory CIDP, poems and autoimmune neuropathies are the first one. If you're sure that it is CID, I mean, demyelinating neuropathy, it's the first thing to come to your mind. Yeah, it's a great presentation. Thank you, Hira.
Thank you, sir.
Thank you.
Absolutely, but this move is slightly surprising to me that wherever the antibody is positive, it moves out of the spectrum, which is the spectrum is not antibody bound. The spectrum
Personally,
is
I think
clinical, electrophysiological. So I'm not too comfortable with this.
I
But
think
I suppose, like you said, it will go out and it will come back.
Personally, I believe all GBS, CIDP, ADP, everything are nodopathies and paranodopathies. It just
Exactly.
some antibodies we know, some antibodies we don't know. That's all.
Exactly.
Yeah.
Exactly. They are immune, they are acquired, and then moving them out just because you have found the biomarkers, it doesn't seem too logical. But that's the way it's going, like you pointed out. Yeah.
Yeah. True, sir.
Yeah.
Thank you, Dr. Hiral. So we move on to the next talk. And the next talk is by Dr. Anuradha Mato. She is a senior resident at Department of Neurology, Grand Medical College, and she will be talking on refractory myositis. Welcome, Dr. Anuradha.
Good evening, everyone. Thank you, sir. I'm Dr. Anuradha Mathur, Senior Resident from JJ Hospital, and I'll be speaking on refractory inflammatory myopathy. So my talk will go through the classification. I'll be discussing two cases: the conventional approach to the diagnosis and treatment of inflammatory myopathy, and refractory inflammatory myopathy, its diagnosis, approach, and the treatment. So idiopathic inflammatory myopathies, these are rare, heterogeneous, and chronic autoimmune conditions which are characterized by not only the inflammation in the skeletal muscle, but they also have
Dr. Mathur, your slides are not visible.
Slides are not seen.
Okay, yeah. Is the screen visible now, sir?
Yes, yes, now visible.
Oh, sorry. These are the rare heterogeneous and chronic autoimmune conditions characterized by inflammation in skeletal muscle with extramuscular manifestations. And the treatment response varies in different individuals. And apart from the traditional treatment approaches, novel biological therapies that target various pathways are being explored. To begin with the classification, the recent or the current classification that is being accepted is it is divided into dermatomyositis, which has antibodies to anti-MDA5, SAE, NXP2, TIF1, gamma. Then immune-mediated necrotizing myopathy, which include SRP, HMGCR, and unknown autoantibodies, which they are labeled as seronegative. And then inclusion body myositis, which is associated with anti-5C1A antibodies and certain class which have unknown antibodies, and anti-synthetase antibodies with overlap myositis. Let me walk you through one first case. Is a 14-year-old male who presented with 1.5-year history of progressive pure motor symmetrical proximal lower limb, followed by 6 months later with proximal upper limb weakness without fatigability, pain or cramps, skin rash, dysphagia or respiratory complaints. When he came to us in the first admission, his CPK total was 12,000. EMG showed myopathic pattern without any spontaneous activity. The distinct feature of this patient was that he had calf hypertrophy. So thinking in terms of DMD, BMD phenotype, his MLPA was sent and it came negative. Then it was decided to send clinical exome, which was negative. A myositis panel was sent in view of the upper limb involvement within 6 months of the lower limb involvement, which came to be negative. It was decided to treat him with injection MPS for 5 days, and then injection IVIG was given for 5 days, and he improved with the CPK also declined. When he came to us in the second admission, his weakness again started in the similar manner. He had lower limb proximal weakness and upper limb proximal weakness. This time we decided to send extended antibody panel, and in which HMGCR antibody came to be positive. His MRI thigh was done, which showed dystrophy in the posterior aspect of the thigh, posterior muscles of the thigh. Muscle biopsy also showed dystrophic changes. Considering his antibodies, HMGCR antibody positive, we treated him with IVIG and he improved. It was in July 2023. In October 23, again he got admitted and he was again treated with IVIG, and it was decided to treat him with rituximab. Now he has been admitted with us now in February with the 4th admission. His CPK are raised. He has not his weakness has not improved as it had improved during the first admission. This is the second case. He's a 25-year male with initial skin involvement, and soon he developed dysphagia, later hip and shoulder girdle weakness over 2 months with ILD. And when his myositis panel was sent, he came to be anti-MDA5 positive. He had not responded to steroids and IVIG and has been planned to be treated with rituximab. So what is the approach to the diagnosis and treatment of immune inflammatory myopathy? What we usually follow is when we suspect, we see in the inflammatory myopathies, proximal weakness, elevated creatine kinase, plus minus myopathic changes on EMG. If the progression is over the years and a typical weakness in the finger or wrist flexors with knee extensor weakness greater than the hip flexor weakness, we have to rule out inclusion body myositis. If it is not so, we have to rule out the clinical or paraclinical findings which suggest the mimics. And if they are not there, then we have to see whether there is immune checkpoint inhibitor exposure, rapidly progressive ILD, rapidly progressive or severe weakness, and skin changes. If yes, then we have to stop the immune checkpoint inhibitors if the patient is exposed to, and if there are other features, then we have to start the patient on aggressive immunosuppression and order muscle biopsy and test for myositis specific antibodies. If it is not so, then we have to see the skin changes, lung, heart, GI, order the extended myositis antibody panel, and consider MRI muscle. Then we have to look whether the clinical and paraclinical findings are consistent with typical treatable inflammatory myopathies, that is the enzyme levels, MRI, and the antibodies. And we have to go ahead with muscle biopsy, nerve conduction study, and if there are clinical imaging and electrophysiological findings which are consistent with treatable IIM, then we have to start the immunosuppressive agents, refer to physical therapy, and screen for cancer. This is the flow chart that we follow in treatment of idiopathic inflammatory myopathy, depending upon the severity. If it is not severe, oral prednisolone 1 milligram per kg per day or IV methylprednisolone is given for in a dose of 0.5 to 1 gram per day for 3 to 5 days. And then if the patient improves, we can consider steroid taper. And if the steroid requirement is more than 7.5 milligram per day, then we have to add steroid sparing treatments. If the patient is not improving, then we have to consider adding IVIG, or we have to reconsider the diagnosis if he is not improving. If the patient presents with severe idiopathic inflammatory myopathy symptoms, then we should go ahead with IVIG 2 gram per kg per meter square plus oral prednisolone should be added, or we can treat the patient with IV methylprednisolone and then start on oral steroids. Now again, we have to look for the improvement. Now, how long should we wait for this improvement? We should wait for 2 to 3 months and see whether the patient is improving or not. If the patient continues to improve, we can continue the above treatment and begin the steroid sparing treatments, which will include methotrexate, MMF, and cyclosporin. If not, then we have to continue the above treatment and consider adding rituximab. After adding rituximab, we have to again see for the improvement for 2 to 3 months. And if the patients improve, then we have to taper the steroid and keep him on maintenance IVIG. And if not, we have to consider another immunotherapy like cyclophosphamide, consider plasma therapy, or reconsider our diagnosis. Now, what is refractory inflammatory myopathy? So there are several criteria that are given for it. And we can say that refractory idiopathic inflammatory myopathy is defined as intolerance to or an inadequate response to glucocorticoids and at least 2 other conventional immunosuppressive or immunomodulatory agents, that is the first line treatment, and rituximab, which can be given to patients with myositis specific or myositis associated antibodies. So the point of discussion here on will be to if we think that if the patient has refractory inflammatory myopathy, we have to evaluate whether remaining clinical manifestations are due to persistent inflammation, or could it be due to damage caused by the previous inflammation or the side effects of the treatment. Whether the diagnosis is correct, and different subgroups of patients will respond variably to different therapies. Selection of treatment for the individual patient and patients with different organ manifestations, because inflammatory myopathy doesn't only come with muscle weakness, they will also have extra muscular manifestations that have to be dealt with. So the first point, whether it is persistent inflammation or damage, which can be either due to the muscle weakness or problems like skin rash, dysphagia, or dyspnea due to ILD. So there are 4 points that I would like to discuss: whether there is a score to assess disease activity and treatment response, whether there is role of muscle enzyme when the patient presents with recurrent weakness, the role of MRI, and the role of muscle biopsy. So there is a score which is given by the International Myositis Assessment and Clinical Studies Group Disease Activity, co-set measures, which has been used in trials, but it can be applied to our patients to assess the disease activity and the treatment response. The response characteristics include the physician global disease activity, patient global disease activity, manual muscle testing in 8 muscles, health assessment questionnaire, extramuscular disease activity, that is dysphagia, ILD, and skin rash, and muscle enzyme. Is there a role of muscle enzyme when the patient presents with weakness? So it may not, it is considered as a list specific one, because it may normalize with glucocorticoid therapy, and maybe the muscle enzyme may not be raised when the patient comes to us with refractory myositis. MRI of the muscle, it is a sensitive tool to assess inflammation, which will show high signal intensity on stir and fat suppressed T2 weighted images of the muscle edema, and muscle atrophy and replacement of muscle with fat and connective tissue, which will tell us that the muscle atrophy has set in. Muscle biopsy is definitely useful to confirm the inflammation and to exclude other causes of persistent weakness. The lung symptoms have to be dealt with repeating the PFT, HRCT lungs to be done whenever required. Dysphagia has to be evaluated by video fluoroscopy, fiber optic endoscopy, evaluation of swallowing, and esophageal manometry. The second point, whether the diagnosis is correct or not. If whatever we have followed, we have treated the patient, and with the patient has weakness, which we are labeling as refractory, we should begin with a new clinical examination with muscle strength testing, repeat the screen for autoantibodies, repeat muscle biopsy to confirm inflammation and exclude the signs of IBM, that is rim vacuoles, and to rule out other myopathies that may mimic inflammatory myopathies, genetic testing, and for patients without skin rash, possibility of IBM, immune-mediated necrotizing myopathy, or a muscle dystrophy should be considered. We should not forget, initially in the evaluation, we should always rule out if in a patient with refractory myositis, whether he has IBM or not. This is a 54-year male who had presented with bilateral asymmetric quadriceps weakness and left finger flexor and wrist flexor weakness, which was more than the right, and was of 5-year duration. This is a flow chart which will summarize the whole approach to the patient with refractory immune-mediated myopathy with persistent muscle weakness. Now, the first is to determine if it is active inflammation or damage, whether there is impaired muscle performance, elevated enzymes, evidence of edema on MRI of the muscle, and whether there is abnormal muscle biopsy. If all these things are not there, we can consider to taper steroids and optimize the exercise. If yes, then we have to look whether there is a presence of skin rash or not. If it is there, then repeat the cancer screening. If positive for malignancy, we have to refer to the oncologist. And if not, we have to consider a probability of refractory IIM. If there is no presence of skin rash, we should, and if there is persistent extramuscular organ involvement or myositis specific antigen or myositis associated antibody positive, then it is highly probable that the patient has refractory inflammatory myopathy. If all this is negative, then we should consider muscle dystrophy and other myopathies. Now, what are the treatment options for different clinical manifestations? I'll cover this in the following points. The inflammatory myopathy with persistent active inflammation, the disease in autoantibody defined subgroups, refractory lung disease with persistent inflammation, refractory skin rash, and refractory dysphagia. So refractory myopathy with persistent inflammation, we know that the first line treatment is glucocorticoids with azathioprine or methotrexate. The second line agents that we can add is MMF, cyclosporine, tacrolimus, or combination of methotrexate and azathioprine. The third line treatment include rituximab, cyclophosphamide, ACTH, abatacept, tocilizumab, and the recent one is JAK inhibitors. Now, apart from the conventional immunosuppressive therapy and having ruled out other myopathies and the possibility of IBM, we still need to change the treatment, and it has to be undertaken quickly. Here, I would like to say that rituximab is particularly effective in juvenile onset disease, positive myositis autoantibody profile, and patients with lower burden of disease damage. When we start the treatment, I had mentioned earlier also that the measurable effects on muscle performance can take time, and at least 3 months should be allowed to measure objective improvement of muscle performance, and physiotherapy and occupational therapy is important for the management. Now, what are the treatment options in refractory disease in autoantibody defined subgroups? Antisynthetase syndrome, which is the largest antibody subgroup associated with multi-organ involvement. One manifestation can respond to a particular treatment, whereas the another may be refractory to the given treatment. If no response to conventional therapy, that is the first line and the second line, it may improve with rituximab. Also, refractory ILD associated with antisynthetase autoantibody may respond to treatment with rituximab. Anti-MDA5 antibody, this is a specific challenge because it comes with rapidly progressive ILD and can be refractory to high-dose glucocorticoid in combination with cyclophosphamide or rituximab. So trials have said that a triple combination of high-dose IV glucocorticoid with cyclophosphamide and calcineurin inhibitor like tacrolimus is recommended. In refractory cases, we can add immunosuppressive drug to the current therapy, or we can switch from one agent to other. Third step is that they have also said the role of high-dose IVIG or plasmapheresis or polymyxin B. Polymyxin B has been used as a hemoperfusion therapy in endotoxic shock. Now it is being used in cases of idiopathic pulmonary fibrosis and exacerbation, where it is said that this therapy reduces, excludes the inflammatory agents like cytokines and inflammatory cytokines and active in lymphocyte, that is neutrophil, and improves the lung function. If this is not, if the patient is still not responding, we have to plan for lung transplantation, and it should be initiated immediately till the patient is awaiting transplantation. Extracorporeal oxygenation therapy should be initiated. Recent new potential effective treatment is with JAK inhibitors, that is tofacitinib. Anti-SRP positive myositis responds best with rituximab, and anti-HMG-CR responds with high-dose IVIG. So to summarize, the patient with IIM and persisting muscle weakness and signs of inflammation in the skeletal muscle, despite glucocorticoid and with the glucocorticoid sparing immunosuppressive treatment, having ruled out the other causes, we have to switch to the glucocorticoid sparing immunosuppressive treatment with azathioprine, methotrexate, and MMF. If the patient doesn't improve, we have to consider this patient for IVIG or rituximab. If the patient improves, we have to taper the steroids and keep the patient on maintenance IVIG and rituximab. If the patient is not improving, then we have to consider a switch to JAK inhibitor or abatacept. Now, if there is no skin rash, dermatomyositis, with myositis, we have to see whether the patient has myositis-specific antibodies. If it is anti-synthetase antibody, we have to consider adding rituximab. If it is anti-SRP, again, rituximab is the drug of choice. Anti-HMG-CR antibodies, we have to consider adding IVIG or rituximab. If all this is not positive and the patient is refractory, we can consider adding IVIG, abatacept, leflunomide, TNF inhibitors, ACTH. Now coming to the patient who presents with refractory ILD. Now this refractory ILD has an increased risk with anti-synthetase syndrome, anti-MDA5 and scleroderma overlap. So we should always screen the patient to refractory ILD by chest X-ray, PFT and HRCT lung wherever indicated. And management should be carried out along with ILD specialists and respiratory physicians. If the patient has moderate ILD, we can go ahead with glucocorticoid with MMF or calcineurin inhibitor. And if the patient improves, we can continue these agents and start tapering steroids. If the patient is not improving, we have to add rituximab or cyclophosphamide and continue the patient with rituximab or cyclophosphamide therapy. If the patient doesn't improve, we can combine both of these treatments. In case of severe ILD, glucocorticoid with cyclophosphamide and calcineurin inhibitor, or glucocorticoid with rituximab and MMF. If the patient improves, we can keep the patient on the maintenance therapy and taper steroids. If no improvement, again, we can combine the treatment with rituximab, cyclophosphamide. However, this will carry more risk of infection. And if the patient does not improve with all this, we have to plan the patient for lung transplantation. Refractory skin rash treatment includes hydroxychloroquine, and if there is severe and refractory skin rash, we have to consider for high-dose IVIG, rituximab, cannabinoids that is coming in treatment, lenabasum, JAK inhibitor. Other beneficial effects with other drugs like abatacept and tofacitinib has been described. Severe pruritus responds to apremilast, and refractory mechanic hands can respond to ustekinumab. Of note, note should be taken that cutaneous or subcutaneous calcinosis should be considered as a sign of persistent inflammation and should be considered as an indicator to optimize immunosuppressive therapy. Refractory dysphagia, we have to collaborate with the speech therapist and other experts on dysphagia. The risk of dysphagia is increased with anti-NXP2 antibody, SAE, myositis, and occasionally with anti-MDA5 and malignancy. The patient is treated, dysphagia is recognized as an indication for IVIG, and the patient should be treated with high-dose IVIG. Other immunomodulatory therapies have been reported to improve symptoms. And if there is persistent dysphagia, and which can be explained by dysmotility of the pharyngeal muscles, which is due to the low endurance, it may not respond to any immunosuppression or surgical therapy, and the patient might require percutaneous gastrostomy to allow adequate supply of the nutrition. Now, what is the role of cancer screening in this patient? So, screening should always be particularly considered in those with older age of onset, male gender, dysphagia, cutaneous necrosis, rapid onset disease, positive anti-TIF and NXP2 and autoantibodies, negative for known myositis-specific autoantibodies. And risk of cancer should always be considered in all patients with resistance to immunosuppressive therapies. So after all this discussion, like there are a lot of immunomodulatory agents and novel therapeutic agents that are coming, and this is the list of drugs that have been tried and which are coming up: rituximab and IVIG. Then the newer ones are tocilizumab, which is tried, abatacept, CD28 and CTLA4 co-stimulatory molecule, tofacitinib, which is a JAK inhibitor, anti-TNF agents like infliximab, etanercept, anti-interferon alpha inhibitors like cefalimumab, apremilast, which is a PDE4 inhibitor, and newer is cannabinols receptor type 2 agonist, which is lenabisome. Now, the question is whether the autoantibody testing is useful or not. Yes, myositis-specific antibodies or myositis-associated autoantibodies can facilitate the diagnosis. They can inform about the disease phenotype and prognosis, and they can help tailor the treatment. And titers, however, titers should not be used to monitor the disease activity. So to summarize this, the treatment of refractory IIM remains challenging and often requires combination treatment with multiple immunosuppressive agents. Monoclonal antibodies and biological agents offer great potential for target-specific treatment. Due to lack of large, well-controlled studies, response criteria for assessment of treatment efficacy is not well established, and target-specific therapies, they continue to improve our understanding of the disease and mechanism and further optimize treatment. These are my references.
Excellent, Dr. Anuradha, excellent. And I think for the want of time, we'll just take one question. How long would you wait before you call it as a refractory?
Yes, sir. The thing is that when we start the patient on the first line immunotherapy, that is the glucocorticoids, and then when we switch and combine the first line therapy, that is methotrexate and azathioprine, we should always wait for, it is said that to wait for 3 months to look for the response. We have to look for the response, and if the patient comes with recurrent weakness, then we have to actually consider what we have done. The flow chart that I had showed, that we have to see the enzyme levels, we have to see the MRI, and we have to decide whether we want to switch to other agents and see the response. And if the patient is not responding, then we should consider the patient for treatment with higher agents like rituximab. And obviously rituximab, nowadays the people start with the when the response is not after 3 to 6 months. So rituximab is for certain antibody-specific myositis, it is considered as a first line. But the patient, we should wait for 3 to 4 months to see the response of the treatment before considering switching to the therapy, other therapies.
Thank you. Thank you so much, Dr. Anuradha. Thank you so much.
Thank you, sir.
I think for the want of time, we have to move on quickly. One more talk is remaining. Now, the last talk of the day is by Dr. Megha Dhamne on refractory myasthenia. Dr. Megha Dhamne is a consultant neurologist and a neuromuscular expert at PD Hinduja Hospital here in Mumbai, and she will be talking on refractory myasthenia. Welcome, Dr. Megha.
Thank you so much, sir. I think you're going to go into refractory listening with so many refractory talks. All right, let me share my screen. One. I don't know. Is it visible?
Ma'am, it is visible. You just need to go full screen. Yeah. That's
Okay. Okay, so let me begin my talk with this case. I love to begin with a case. So this was a 19-year-old girl. She was sent to me for considering because she was diagnosed as refractory myasthenia. So I saw her in June 2022. She had been diagnosed with myasthenia gravis, generalized with ocular bulbar symptoms since 2020. Initially, she was on omnacortil, responded very well to omnacortil, received high-dose steroids, few months, tapered off and stopped, I think, over a period of 6 to 8 months. And she was on ASA 50 twice a day. It's a very typical scenario that we see in our clinic. She was MGFA grade 3A, which is a moderate disease with more of bulbar symptoms, basically. So what happened, do we call her as refractory? How would you treat her are the questions that you face in your clinic. Okay, so when MGF, there are various definitions of refractory myasthenia, as we have seen with other diseases as well. But so this definition suggests MGFA post-intervention status is unchanged or worse after corticosteroids. At least 2 other immunosuppressive agents used in adequate doses for an adequate duration, with persistent disabling symptoms or side effects that limits functioning, or frequent clinical relapses on lowering immunotherapy. And patient has side effects from immunotherapy. So definitely this patient, we go back to her, she had disabling symptoms. She had proximal weakness. She was MGFA grade 3. And we could not lower down her corticosteroids. So what I did is I went back on the dose of corticosteroids. She was only on 5 milligram of omnacortil. I could not lower down her steroid dose. And I offered her rituximab. Okay. However, again with rituximab, she was not very well managed, and we had to do thymectomy. And only after thymectomy, her symptoms came under control. So it was a combination of treatment approaches that we need to use in these patients before they are in remission. Now it's 1 year down the line, she's completely in remission. Now, talking about myasthenia gravis, we know it's an autoimmune disease caused by antibodies that bind to the postsynaptic proteins at the neuromuscular junction. Prevalence of myasthenia seems to be higher today. We are definitely seeing more cases of myasthenia, maybe because of the more elderly population or more sensitive tests. So the subgroups of myasthenia gravis determines the type of treatment we offer to these patients. Hence, it's important to know the various subtypes: early onset, late onset, thymoma associated. Different antibodies define the clinical prognosis of these patients: MuSK, LRP positive, seronegative, and whether the disease is ocular or generalized myasthenia. This is a very beautiful diagram which shows what happens to the neuromuscular junction in myasthenia gravis. On the left, you can see the acetylcholine receptor and the number of folds at the neuromuscular postsynaptic membrane, which is reduced in a patient with myasthenia gravis. Okay, so talking about what happens to the neuromuscular junction, what is the pathophysiology, and that would be important when we talk about different therapies in myasthenia gravis. So different antibodies, transmembrane and intracellular. Commonly, acetylcholine receptor antibodies, they either act by blocking the receptor, binding the receptor, and formation of membrane attack complexes that damages the postsynaptic membrane. The third mechanism is by increased acetylcholine receptor internalization and degradation. Now here on the left, we have these proteins, agrin, LRP4, with a combination of MuSK. What they do is they play a role in the clustering of the acetylcholine receptor at the postsynaptic membrane. Rapsin also helps playing a role in cross-linking of the acetylcholine receptor, and that helps in clustering of the acetylcholine receptor and stabilizes the membrane. Now, the other antigens, ryanodine receptor, antibodies have been found, myosin, actin, cortactin, titin. You will see these antibodies in patients with thymoma, and the presence of these antibodies will indicate a poor prognosis, or they may be markers of thymoma, but the actual pathogenic role is not very clear of these intramembrane antibodies. Now, coming from the neuromuscular junction to the actual pathogenesis, what happens? What is the thymus and where is it? Why are we looking at thymectomy in myasthenia gravis? So I explained to my patients in a way that, it is a disease where it's a battalion which we are training, right? So thymus is the training center here. So we have the T cells which are being trained here in the thymus. And the way they are trained is by central tolerance and by peripheral tolerance. So what happens is you have IR, which is autoimmune regulatory gene, which is expressed in the thymic medulla, and that regulates the recognition of self-antigens by the T cells. So the T cells which recognize the self-antigens are destroyed. And this is called as the central tolerance. And the ones which are not destroyed, which are the self-reactive T cells, again will be destroyed by peripheral tolerance. Okay, so the central tolerance is actually defective in patients with myasthenia gravis. Late onset myasthenia and musk myasthenia, there is not much role of these of thymus. What about B cells? Because we keep talking about B cell depleting therapies in myasthenia. So a normal thymus does not have germinal centers, but a patient with myasthenia has thymic hyperplasia, which is characterized by high number of germinal centers. And it is here where the proliferation of antigen-specific B cells and affinity maturation occurs, and the mechanism is similar to what happens with the T cells. So antigen specific B cells are produced here, and these are the ones which are causing acetylcholine receptor antibodies. So it's a very complex mechanism which is happening, and that's where the role of thymus is there in myasthenia gravis. Now, switching to the natural history, what happens typically to our patients with myasthenia gravis? So most of them will be generalized, but a minority of them, 17% of myasthenia, may remain ocular. They begin with ocular and they remain ocular for 2 years. And those who remain ocular for 2 years, most of them, we can be about 90% sure that they will not be generalized, right? So the natural course of myasthenia is improvement in 57%, remission in about 13%, after the first 2 years. Only 20% remain unchanged. Mortality from the disease is very small, 5 to 9%. Only 4% of those who survive the first 2 years become severe than at the time of maximum weakness. Now, there is no clinical correlation between the acetylcholine receptor antibody levels and the severity of myasthenia. These points are important for us to remember when we are treating a patient, because most often the question comes, should we correlate, should we do acetylcholine receptor antibodies? So these points are important for us in patients with myasthenia gravis. Now, this is one of my favorite slides, which talks about the natural history of myasthenia gravis. If you look at the slide, in early 1900, there were few treatments available for myasthenia gravis and the mortality was very high. But after the introduction of effective ICU care, ventilator management, positive pressure ventilation in 1957, 1966 is where the ACTH and steroids were introduced and plasma exchange from 1975. And now it's a completely different era of antibodies that we're talking about, B cell depleting therapies. So this has definitely brought down the mortality and the morbidity of our patients with myasthenia gravis. So coming back to which patients are called refractory myasthenia gravis and how do we treat them? Failure to respond adequately to conventional treatment, inability to reduce the immunotherapy without clinical relapse or need for ongoing rescue therapy, intolerable adverse effects, comorbid conditions restricting the use of conventional therapies, and frequent crisis. This was the largest study of patients, I think 1,500 or so, who had refractory myasthenia gravis. The typical clinical features of these patients, the characteristics were younger age at onset, females, generalized myasthenia at onset, predominantly bulbar symptoms at onset, severe events or severe crisis, severe relapses, MuSK-positive myasthenia and thymoma associated were the ones who were refractory myasthenia gravis, which is also shown in these studies. So, understanding the burden, we talk about a small number, but if you see, these refractory patients have risk of crisis, higher myasthenic exacerbations, maximum ER visits, and inpatient hospitalization. So the number is small, but the impact is huge on quality of life. The cost of treatment is quite high, and hence we need to find out how do we treat these patients, because often we see that we are lost. We are trying everything, but then we are lost in treating these patients in achieving the remission. Before we move on to the treatment, let's discuss this case. So this patient was referred to our facility. He was a 58-year-old male, known diabetic, and my colleague admitted him saying that, he's a case of refractory myasthenia crisis. He received 5 sessions of plasma pheresis, solumedrol, and he wanted to give rituximab to this patient. So when I saw him, he had clinically quadriplegia, grade 1/5, no ptosis, no eyelid fatigability, no neck or bulbar weakness. He was on a tracheostomy on room air. So let's pause for a minute. There are 2 important things that we see here. One is, see, this patient has received IV solumedrol. 2, I wondered, he's got a severe quadriplegia, severe weakness, but no neck muscle weakness. So, such a patient, before you go ahead and treat with rituximab or escalate the therapy, as Dr. Vishnu correctly pointed out, we need to find out if this patient is really a refractory myasthenia, or are we dealing with another pathology here? Okay, IV steroids do increase the risk of critical illness neuromyopathy, and that was suspected because there was a discrepancy in the clinical exam here. So I did the nerve conduction EMG, and it did show myopathic units. And he was a diabetic, so that was, he did have a neuropathy, but definitely there were myopathic units. So sometimes in these patients, you have to take a pause and say, no, we do not need rituximab in these patients, do not escalate. This patient did turn out to be critical illness neuromyopathy. And over the next 2 to 3 weeks, he improved. So when we talk about the treatment of myasthenia gravis, we take into account clinical features, antibody subtype, the disease severity, before we decide what do we need to plan for these patients, which is along these 4 lines: symptomatic treatment, treatment of severe disease or crisis with IVIG and plasma pheresis, which can be continued as the maintenance therapy in some patients, using long-term therapy with steroids or steroid-sparing agents and thymectomy, and then talking about novel therapies. So I'm going to skip this slide. Oral prednisolone, mean response rate about 74%. It's limited by the side effects. Right, steroid-sparing agents. There are multiple agents which have been used for myasthenia. However, we do not have evidence. Most studies are non-random. Many of them are simple observational or anecdotal studies. Side effects limits the use of these treatments, and the onset of action is months, and hence it is difficult for us to use these therapies when we want a rapid response in patients with severe myasthenia, right? So in these patients, then we use IVIG or plasmapheresis, and we wonder which is a better option. So this study, which was done by Barth in 2011, was published in Neurology, showed that both of them have a comparable efficacy in patients with moderate myasthenia. So when do we use them? We've discussed it, myasthenia crisis or worsening, pre-thymectomy for preparation of the surgery. It can also be used in maintenance treatment in refractory myasthenia. In fact, we've used a lot of IVIG maintenance as well as plasmapheresis as maintenance therapy in the US, where you would start with plasmapheresis 5 sessions and then spread out to once a week, once in 2 weeks. But it is difficult in our Indian setting because of a lot of logistic issues that plasmapheresis is going to be difficult to send the patient out at home, and do it like a dialysis patient, but it is still doable in patients who you can have this as an option. So how does it work? Plasmapheresis removes the antibodies, cytokines, adhesion molecules from the circulation, and IVIG has multiple effects, including inhibition of complement deposition, blockade of activating Fc receptors, neutralization of cytokines and antibodies. Subacute IVIG has also been shown to be beneficial in myasthenia and exacerbations. Now, talking about thymectomy, we have seen the role of thymus in myasthenia gravis, and Gil Wolf in 2016 published this study, which was a randomized control, and it provided evidence supporting the use of thymectomy for improving the clinical outcomes and reducing the need for immunosuppressive therapy in myasthenia. Indications: all patients with thymoma and carefully selected non-thymomatous myasthenia. Like how we decided about going in for a thymectomy in our patient, which I discussed to you about, the young patient who was refractory to high-dose steroids, azathioprine, rituximab, who improved after a thymectomy. So we have to select these patients who are non-thymomatous, and early thymectomy helps in these patients than waiting for a longer duration of disease. Now, what about MuSK myasthenia? Pyridostigmine may worsen symptoms. This is an IgG4 mediated disease. Hence, it does not activate the complement cascade pathway, unlike acetylcholine receptor antibody myasthenia. Hence, plasmapheresis is preferred, and complement inhibitors would be ineffective in these patients, and they respond very well to B-cell depleting therapies. Now, hence, because the remission in conventional therapies is 70 to 80%, many require long-term therapies, and we are limited because of the side effects, with 10 to 15% which are refractory, but still it increases the morbidity and the financial burden. We do need targeted therapies, and that's the reason why a lot of research is being done here. There are a lot of newer therapeutic targets in myasthenia, as shown in this cartoon. Here I would like to talk about the B-cell depleting therapies in myasthenia. So this diagram shows the B-cell lineage. It's important for us to know this because of the target that we are using here is anti-CD20, so which is rituximab. So it is present, if you see, on the pre-B cell up to the memory B cell. It does not cover the pro-B and the stem cell. It does not cover the plasma cell. I'll come back to this slide later. So rituximab is a monoclonal antibody targeting the anti-CD antigen, CD20 antigen, and it modulates the B cell activation and inhibits the acetylcholine receptor antibody-dependent cytotoxicity. So several retrospective uncontrolled studies supported the efficacy and the safety of rituximab in myasthenia gravis. And after that, there was a BEAT-MG trial, which was a phase 2 trial, which was an acetylcholine receptor antibody positive generalized myasthenia gravis. But despite the retrospective observational studies which proved its efficacy, this well-designed trial failed to meet the primary endpoint. So it did not show a reduction in the prednisolone dose, clinical stabilization, or improvement in neurological status. However, the post-hoc analysis showed fewer relapses in the rituximab group, and we wonder why the trial failed. So can we not use rituximab in myasthenia gravis, which is acetylcholine receptor positive? Let's see why, and can we use it or not? So subsequently, there was another study which came up, which showed a good difference in the primary endpoint. This was a Renomax trial. In fact, they used 500 milligrams of rituximab, and it did show a significantly lower myasthenia scores in those patients who received rituximab. Okay, so if we are using rituximab, when do we use it is the question, and that could answer why the Beat myasthenia study may not have succeeded. So, as was seen in this trial, this was a comparison between rituximab treatment in new onset generalized myasthenia gravis. These patients who were new onset did much better when used rituximab earlier on than if you're using rituximab in the refractory cases later in the disease. And that possibly could be because of irreversible neuromuscular junction in those who are having a longer duration of the disease and presence of long-lasting plasma cells in the bone marrow in these patients in acetylcholine receptor antibody myasthenia. So coming back to the slide where you have the B cells targeted on the pre-B cell to the memory B cell, the plasma cell does not carry the anti-CD20 and that escapes the anti-CD20 mechanism of action. And that's probably the reason why these patients who have long-lasting plasma cells are escaping from the action of rituximab. And in these patients, we may need more rituximab cycles and for a longer duration to get rid of these longer lasting plasma cells, or we may have to use CD19 depletion therapies, which will cover a larger fraction of anti-CD, a larger fraction of B lymphocytes. All right, so these could possibly be helpful in patients who are resistant or refractory to rituximab. Now, what dose and how long? There are different regimens and different protocols. Renomax showed that a low dose 500 milligrams rituximab can help when used early in myasthenia gravis. There are certain risks that come with B cell depletion. Newer therapeutic targets have been approved now in generalized myasthenia gravis, complement inhibitors and FcRn inhibitors. The first complement inhibitor which was approved after the REGAIN trial was eculizumab. It has shown its benefits and sustained benefits up to 52 weeks with very minimal side effects. Subsequently, ravulizumab and zilucoplan have been tested in clinical trials. I think we will await long-term safety and efficacy of these agents. Talking about FcRn blockers, now it's a very interesting concept here which was used, is the FcRn interferes with recycling, the blockers interferes with the recycling of antibodies. So when you inhibit the FcRn receptors, it actually reduces the levels of IgG and the pathogenic antibodies in the circulation, and it is defined as a medical plasma exchange because of the rapid reduction of antibodies in the plasma. It's interesting that this is more selective for IgG reduction, and hence the other antibodies are not affected by FcRn receptor antagonists, and maybe that will be helpful for us when we talk about increased risk of infections because of depletion of these antibodies. Efgartigimod is approved for treatment of generalized myasthenia gravis, and improvement in strength and quality of life was seen across all the 4 myasthenia gravis scales as shown here. Benefit was seen early and was sustained. What would be the advantage over plasmapheresis? The longer lasting effect, selective reduction of the IgG subclass, and it does not remove the complement, all the antibodies, cytokines, and adhesion molecules from the circulation. So these may offer innovative approaches to treat myasthenia gravis. Other FcRn receptor blockers have also been tested. They have a promising role in the management of myasthenia gravis. Other strategies that could be tried and which have been studied are pulsed IV cyclophosphamide, autologous stem cell transplant, periodic plasmapheresis, and maintenance IVIG, as I discussed with you previously, is a standard treatment in the Western population that, if they are refractory, you would spread out the plasmapheresis sessions or IVIG sessions. But now with the newer therapies, this probably is not going to be, we're going to see a new change in how we treat myasthenia patients. So a lot of drugs are there in the pipeline. Emerging therapies in other autoimmune diseases are being explored in myasthenia gravis. This was a recent paper in Lancet that was published. CD19 CAR T cells. In fact, my husband is working on these CD19 CAR T cells in treating pediatric lymphomas and leukemias. This was the last, the first successful treatment of CAR T CD19 in a patient, you can see, who had a severe refractory myasthenia. This was a Lancet paper. You can see this patient received steroids, rituximab, bortezomib, IVIG, and mycophenolate, and still was refractory to treatment. And she received CAR T CD19 and has been in remission. So it's an exciting time for all of us, with approval of several new agents with novel immunological mechanisms of action and a broader choice of treatment options for us in patients with myasthenia gravis. So as more treatment options are added, the optimal placement, how do we use this, will change over time. And that's my ending slide. Thank you so much.
Thank you, Dr. Megha. It was excellent. And I hope these new therapies which you have mentioned becomes available to us. Otherwise, we are stuck at the same paradigm of treatment. We start steroids and the patient doesn't respond. We escalate slowly.
True. But I would still say that majority of myasthenia respond to steroids. So I think we should start with steroids and we should not jump to rituximab or these novel therapies just because it is available. Because it's, as we said, it's only 10 to 15% who are refractory or who may not. What happens in most of the cases is the steroids are tapered off very quickly. And that's where the patients end up into a refractory. We end up calling them as refractory. Like, that's why I presented this girl. I think her steroids were tapered off very quickly. And that's where we are not able to achieve remission in these patients.
Excellent.
Sir, if you have any comments.
Sir, you are muted.
You're muted, sir.
Yeah, I think steroid is the mainstay. There's no question about it. And people do come down on steroids and pyridostigmine pretty quickly. That is what I have also found. So I think myasthenia treatment is personalized, depending on how that person is doing. You need to decide, and you need to go very long. Also, someone in the question box has put a question: when you're stopping, do you stop pyridostigmine first or steroids first? So maybe we can open it up for a little discussion. I generally stop pyridostigmine first, and then if the patient is still doing well, then at some point in time I'll stop steroids. What does everyone do?
Yes, sir. I agree.
Sir, I often continue with very low dose of steroids. Very low, meaning 10 milligram alternate days, something like that. I try to persist with this low dose,
Yeah, there are very few patients who really get off all the drugs and stay well for years together. It relapses so unpredictable.
Yes, Vishnu.
Yes, sir. Ultimately, sir, for me, when the patient comes and say me, I missed couple of doses of pidostigmine and nothing happened to me. That's the moment when you realize for the patient also to be confident, ki, okay, now I can keep your pidostigmine. I can start pidostigmine at a good amount of time. So that's it.
There is one more question.
I mean, ultimately, for a general purpose, I would say, I mean, there is a difference between neuroimmunology that we neurologists treat and how other systems treat their immunity diseases. We start slow. Other systems, for example, nephrologists, they hit everything they have in the first instance. They throw everything. They throw the whole kitchen sink on this one. That's when they have a spare kidney to manage, and they have an option to transplant their kidneys also. But still, they'll throw the whole thing. If you look to treat the way they treat lupus nephritis, they hit the button, and we somehow treat the other way. We slowly start first steroids, then we'll escalate, then we'll start the second level treatment. Then we'll go to the next level. Probably because brain is not transplantable that easy. We have only one brain, or one muscle cannot be transplanted. Probably that's why we are a little more careful than other system. This one, but there is a stark difference between immunological treatment between our systems and probably the way others treat.
Sorry. So the other thing is IV steroids. I've seen IV steroids being used for myasthenia. So I think,
I use it pretty commonly. If the patient is on ventilator, I pulse most of the time. There's nothing, there is no harm in treating. I use it when the patient is on ventilator. If the patient is on ventilator, sometimes we pulse also. Then we do start on very high dose steroids also sometimes. It helps there is going to be some dip in the initial part, but it will help you in getting across a high dose of steroids rather than stepping it up. But if the patient is not on ventilator or not on this one, I'm not comfortable in pulsing steroids at any point of time.
There is a question of pyridostigmine use in musk. You want to answer, Dr. Megha?
So I think everybody reacts differently. I mean, typically you would avoid, but we have had patients who are on pyridostigmine and they respond. I had this lady I would want to talk about. Sent by an ophthalmologist saying ocular myopathy, CPO, ophthalmoplegia. And I started her. There was no fatigability. There was no dosage. And I started her for some, maybe I was biased. It was some fatigability or whatever. So, or her RNS was borderline. She showed some response, and acetylcholine receptor was negative. I put her on steroids, and later, because she responded much better, her eye movements improved. Then I sent her musk, and she's actually a musk positive myasthenia with complete ophthalmoplegia, no ptosis at all. So, there are some patients who do respond to pyridostigmine. So I wouldn't say not to use completely. So what would you say?
Yeah, there's no harm in sort of starting a very small dose and seeing what is happening, though with the knowledge that they may not do that.
Steroids in ocular myasthenia. I think we can take the last question because it's already over time.
Yeah, so I start with pyridostigmine first. And if they are not under control, then I would use steroids.
I usually give the patient the choice.
Yeah.
So I tell them what you want. There is a chance, this one, or you can just observe and see. We will see on course of time if you want to. I leave it open to the patient. That's after a discussion, then how they want to proceed.
Yeah, I think it will largely depend on what is it doing to them. Somebody working on the computers and a little diplopia also is troublesome. Then one would be a little proactive to use it.
I still remember a patient with a Goldsmith. he literally didn't have clinically it's very differentiated to differentiate whether he had an ophthalmoplegia or not. But he says he has diplopia. So and he says that he can't work. He need precision to do the goldsmith work. So yeah, ultimately, so he initially had a very good response to pyridostigmine, but he was not satisfied with what we had. So ultimately we had to start, and he improved also. Yeah.
Yeah, sir, there was some conflicting evidences that use of steroids in ocular would prevent the generalization. I mean, it's plus minus. Of course, ocular depends on the level
I
of
think
You
Dr.
know,
disease.
Meghna showed the epitome trial
Epitome
also, right?
study. Yeah, I showed the
Yeah,
epitome
it's a
study.
small trial, but yeah.
Small number, small trial, and it just showed, I think, safety and tolerability. But I think they did not comment on generalization, preventing
It's a
generalization.
good research question. Anyone can take it up.
you know, one point I would like to make that in large studies, whoever are called ocular, particularly those who are antibody negative, you really don't know what they are.
Yeah, that's true.
You know, most studies have done only two antibodies or one antibody in the past. So, what is ocular myasthenia in the truest sense of the disease? A myasthenia restricted to ocular? I think there are very few patients. Most quickly go on in general. So I think that the diagnosis itself, unless the antibody is positive, one has to be a little careful about all the differentials. You know, particularly those who are staying long as ocular and nothing happening. I like to go back to them and see what are they? Are they mitochondrials? What are they?
Should we close, Vishnu?
Yeah, yes, sir.
Ready?
Yes.
So, thank you all. We had a very nice session. All three speakers, they have taught us a lot today, how to approach all these refractory syndromes. And we thank them on behalf of the subsection.
And this was the first meeting of this year. We
Yeah.
started with the bang. So
Yeah.
let's hope we can continue.
Yeah.
The next
Also,
meeting,
you know, Rakesh and Vishnu, I would like to compliment you for doing this activity so well in 23, now starting in 24. It's fabulous.
Yes, sir.
Thank
Rajesh sir was very enthusiastic to start it every month, but I ain't told no need. Only once in 2 months is enough.
Yeah.
Lovely.
So the next meeting is on 24th of April. It will be done by the CMC Vellore group.
Yeah.
And so we'll see you then.
Okay.
So
Thank you, sir.
bye.
Thank you.
Good night.
Thank you,
Good
sir.
night.
Thank you, Dr. Meghna. Thank you.
Thank you. Bye, sir. Bye, sir.